Welcome everybody to episode 2 of the activity titled COVID-19 Impact of Caring for Your Patients with Hematologic Malignancies. My name is Sagar Lonial and I'm the Chief Medical Officer at the Winship Cancer Institute of Emory University. We hope that you find this discussion to be both informative and educational. And this is a bit of a reprieve, if you will. This same group got together about a month ago. And so it's a great opportunity, I think, for us to talk about lessons learned and what's changed and what's evolving and where everybody is in terms of what we hope is recovery from what a month ago looked pretty bleak. So let's get us started and meet the colleagues today. First off, Dr. Carlos Del Rio from Emory. Carlos, you want to give us a quick introduction on what you do?
Yeah. Carlos Del Rio, I'm a professor of medicine and infectious disease and professor of epidemiology and global health at the Rollins School of Public Health. And I'm the Executive Associate Dean here at Grady Hospital. My research primarily is in the area of HIV, but I've been doing lately a lot of work around COVID, including participating in the clinical trials, both with remdesivir and the vaccine study.
Thanks, Carlos. And for those of you who live under a rock, Carlos has a chair with his name on it at CNN now. So he's been pretty active in giving us information. Next up, Dr. John Leonard. John, you want to take a moment?
Hi, I'm John Leonard. I'm a professor of medicine and senior associate dean at Weill Cornell Medicine and New York Presbyterian Hospital. Relevant to this discussion, I care for lymphoma patients and conduct clinical and translational research with new drugs and other aspects of care and new therapies for patients with lymphoid malignancies.
Thanks, John. And last and certainly not least at all, Dr. Gail Roboz. Gail, you want to give us the quick thumbnail on you?
Hi, everybody. Gail Roboz. I'm also a professor of medicine at Weill Cornell Medicine and the New York Presbyterian Hospital. Same place with John. We're currently across the street from each other in our respective offices. I am the director of our leukemia program. My specialty is in acute and chronic leukemias, myelodysplastic syndrome, bone marrow failure states, and I run our clinical and translational programs here. And certainly, you know, for this discussion, John will handle lymphoid, and maybe I'll talk about myeloid.
Great, thank you very much, Gail. I appreciate that. And for reference, here are our collective disclosures. This webinar has been provided by BioAscend. BioAscend is an independent medical education company committed to supporting healthcare providers in their efforts to translate innovative science into clinical practice. Support for this webinar has been provided by Astellas, Bristol Myers Squibb, and Karyopharm Therapeutics. So let's go ahead and get started. As I said before, a lot has changed in the last month since we were all four together here trying to provide some guidance and information on how to manage heme malignancies in the era of the COVID pandemic. So Carlos, why don't we start off with you and tell us where we are now with COVID-19, and let's not bring political discussions into. Let's just use data.
Well, I think a couple of things. Number one, I think that one thing that has happened is the U.S. has now passed over 1 million confirmed cases and over 60,000 confirmed deaths. And when we think about where those cases and where those deaths are, a big number of them are in New York State. So obviously our colleagues from New York can say more about this, but about a third of the cases are in New York, and then the rest are really scattered around the country. I think we're beginning to learn a lot more about this virus. We're beginning to learn more about the extent of the virus. Serological studies have shown us that probably the confirmed cases are probably a tenth of what really is out there. When they've done serological studies, we find a lot of people who have evidence of infection, but either had no symptoms or very, very mild symptoms. So when we think there's a million confirmed cases, we got to think that there's maybe 10 million already people infected in the United States. The second thing is we learned that that's important because then the mortality is, of course, a lot lower than we thought, right? The mortality is not 9%, but maybe it's maybe it's, under 1%, probably in the order of 2.3%. The problem is the numbers, right? You're talking about a huge denominator, and when you have millions of people infected, 1% mortality, still a lot of dead people. And again, we emphasize that there's been now more Americans have died of this infection than of that what has died, who died of the entire Vietnam War over 20 years. and the excess mortality that we're seeing as a result of this infection is not trivial. So I don't want to trivialize the infection. This is still a very serious infection, but obviously we're learning a lot of things about the spectrum of disease. One of the things I think with learning symptoms that I think is really interesting is we suspected it, but now it's pretty much confirmed, is that anosmia is a very important symptom, and about 30% of patients report either losing their smell and or their taste. And I tell people that in the morning, my home test for this disease, I wake up and I feel good. I take my temperature, I'm afebrile, and then I go to breakfast and I smell my coffee. And if I can do those three things, I'm good to go. I don't have COVID that day. So anosmia seems to be a pretty important finding. And then I would say that the third thing that I'm going to mention is that there seems to be three areas that are particularly important as hotbeds right now. One is jails, one is nursing homes, and one is healthcare environments where people are still getting infected. And we're doing a very good job, better and better in our healthcare systems of preventing infection. But in nursing homes and in jails, they're not, and we're seeing a lot of outbreaks happening there. Meat plant industry is another area that is right now becoming one of major places where transmission occurs. The final thing is I think we're advancing in therapeutics and in vaccines slowly. In therapeutics today, just now, a few minutes ago, the NIH released the results of the DSMB study of the adaptive remdesivir study, showing that there is a 30% improvement in time to recovery, going from 11 days to 15 days, and a little bit of a trend towards improving survival. Again, not a home run, not a game changer, but evidence that there is hope and that research is going to get us to where we need to go. So we need to continue supporting clinical trials and research in order to find both the cure and a therapy for this disease. And I will stop there.
Thanks, Carlos. That's really helpful. And as we talk about COVID-19 and sort of in global categories, one of the questions that comes up, particularly relevant in cancer, is what about COVID and smoking, COVID and vaping? Are those two things known to be risk factors that might account for some of the younger patients we see that have severe disease, knowing that it typically tends to affect the older ones more?
Well, so again, the answer to that is likely yes. Today there's actually an MMWR released today from the state of Georgia. They looked at 305 hospitalized patients here in Georgia, and they saw the risk factors. And one of the things they realized is that 1 in 4 patients did not have a risk factor. Diabetes, obesity were normal risk factors, but a lot of patients were young, and a lot of patients did not have a risk factor. And among those that were young, smoking was a significant risk factor for disease, for severe disease. So again, emphasizing that damage to the lungs by other things such as smoking and vaping may play a role in severity of disease.
Okay, that's great. And you mentioned remdesivir. I think we're all looking for something other than our gin and tonic to potentially work to prevent COVID-19. What about some of the other approaches, passive immunity? I'm curious if John and Gail, you guys are using antibody infusions from patients that have been previously ill, or what data you guys have, or Carlos, about in that area.
Well, to my knowledge, the convalescent serum is something that's of active investigation. What I have seen thus far is that it's largely kind of single-arm studies, and people get better. Most people have gotten better in those series of patients. I hesitate to really call it a study, but like many things, the single-arm experiences or studies or reports are very challenging to interpret. And I know that there are some international efforts to do some randomized trials, which are either ongoing or getting underway, looking at that in particular. So that's something that is a great area of interest here amongst many other things, but something that the jury is still out, I would say, from my read of the data so far.
Gail, you want to add anything? Have you guys been doing it at your hospitals?
So, I think it's ramping up, but what's going to be interesting to see is what actually is the volume going to be, right? So I think that since the last time that we've spoken, I think I've certainly always hated getting stuck in deep statistics, whether it's college, med school, you can be bamboozled. I sometimes feel like I'm buying a used car when I'm reading these, because the more complicated the statistics, the more we can be bamboozled. And I think that it looks like many of the modeling, much of it has been wrong. I get it. These things are hard to predict. So is the weather. But I don't think we're going to be sitting necessarily on thousands and thousands and thousands of cases at the moment in order to get the statistical power to have the randomized trials that we all thought we were going to be gearing up for. There aren't thousands of people. There isn't any more a vent in every bathroom. There aren't thousands of people on vents. And my concern currently is that on the one hand, so it's hard. On the one hand, we want this to be going in the right direction. The numbers are going in the right direction. We've clearly had an experience here in New York that is very, very different from what others are having across the country and across the world. Again, Italy, France, Spain, different from other areas, different from Sweden, whether or not you attribute it to social distancing or not. The world is not experiencing this in the same way. But what is clear is that there are not 1 million people ready to go onto a clinical trial or multiple clinical trials at the moment. So I'm not actually sure how the excellent ideas that are coming forward for numerous clinical trials, I don't know how that's going to play out, because even in the last month, with the curve changing, there are drugs that are intended to be deployed much earlier, obviously, than when patients are on ventilators. How are we going to run all of those trials if the numbers are actually going in a downward direction, and if, as some of the models predict, there may not be the fully expected phase 2 in the fall? That seemed like it was a given. I have heard very recent data suggesting that not everybody agrees with that at all, and that it's not necessarily a given that there's going to be another phase soon. So how do we run all of these trials?
Yeah, Carlos, you want to speak to that in terms of the fall and what we can all look forward to?
Well, I look forward to getting my job back, right? We all want to get our jobs back and be back to what we were doing before. And I tell people that, nowadays during the week, I define the weeks as time that I Zoom for work, and I define the weekend as time that I Zoom with family. We want to get back to being able to hang out with our families and our friends and go out to restaurants. So I think, that's going to happen, but it's going to happen slowly. And I think the process is still what's difficult here is the uncertainty. As Gail said, is that prediction of the weather that is so hard, And I tell people back in January, there is no way I would have predicted where we are today. So it's hard for me to predict today where we're going to be in 6 months or in 3 months, because back in January, I would have no way I would have said we're going to be where we are today. I'm seeing some positive trends, and I think, we may not know where we are. I think the main thing is that we need to continue to be prepared for the worst. I think, in the fall, if this comes back with a bang, we will have more testing, we will have better drugs, we will be more prepared. I think this caught us all totally grossly unprepared. And I think what we're doing right now is a lot of it is playing catch up, quite frankly. And we may be in a better place in the fall. So I'm not that much worried about what's going to happen next. I'm worried about getting out of where we are right now.
Okay, all right. I remember on our last call, John, you were giving me some rough numbers for your hospital system in terms of total numbers of patients you had in the hospital and total numbers you had in the ICU. Please tell me that those numbers are lower.
No, those numbers are lower, and I would, ballpark them at being, 2/3 of the peak, 2/3 range of the peak. So, I think that's obviously a very, very positive sign. And, we are very focused on making sure, and I think we have excellent plans to do that, making sure that as we ramp up our patient populations in other areas, and over the course of the month of May, I would expect that we won't be 100% back to normal, but we'll be gradually ramping back up, and much of our routine care will be resumed. And as you know, all along, just like at your center's cancer patients and hematologic malignancies patients. I'm sure some of them are waiting, but most of them are not waiting. And so, we're gearing up to make sure that we can take care of them in the numbers they need to be taken care of, and of course, in a way that's safe for everybody. And I think that, in my mind, is largely a doable thing, but it takes some thought and some planning and preparation.
Yeah, no, I think that's helpful. And just from our perspective, I think we have been pretty fortunate that the number of cancer patients that have been positive in our system has been relatively small. And so we do have places to evaluate them and to test them and to get them checked out. But our numbers were relatively small, as I mentioned, and we were able to continue with treatment on a significant proportion of patients, as you mentioned, regardless of the diagnosis. And we did back off on some things like auto transplants and CR1 for myeloma. We've delayed those a little bit, but now we're planning to reinitiate some of those in the coming months and to ramp back up. I'm curious what you all both experienced in New York with your patients in terms of the absolute numbers of patients that actually were sick, what those courses were like, and how it guided decisions on therapy for both of you. Gail, you want to start?
Sure. So it's been a wild ride. Our numbers. So we typically on the leukemia service. This is leukemia only, not transplant, not lymphoma, myeloma. We are generally around 40 on the inpatient service, and we have been consistently 15 to 20, which is super low for us. I haven't had numbers like that in my whole career here. And, it's funny because on the one hand, I call my colleagues in Connecticut and New Jersey and Philadelphia, in the city, and everybody's kind of looking at each other saying, where are the patients? Some of them we know. So some of them have been one by one locked down. So my colleagues and I started locking people down early. I don't want to even speculate as to whether that was a good thing to do yet, because I don't know, but we locked them down fast and early. So there are many patients in remission, many patients who we thought had therapies that could actually wait a little bit to let us figure out what was going on here, that we locked down. So we know where those patients are. And actually, I have been astonished that some had COVID, some didn't. There was absolutely no prediction. There are patients I would have told you would certainly not survive who really had completely benign courses with it. We're still not exactly sure how they got it. Then I definitely have had an increased number of phone calls from other hospitals in the broad tri-state area who would have normally sent me the AML patient that they have, but we couldn't transfer patients in. They weren't sending them. So there's been a lot of phone management for the acute leukemia patients who need to be treated right away in other places. And we treated acute leukemia like acute leukemia. Those patients were in the hospital. I think that many hospitals, including ours, have made specific protocols to isolate those patients in private rooms. We're in the Upper East Side of Manhattan. Okay, real estate here does not allow everybody to always have a private room, which we would love, but it doesn't exist. Now it does for these patients. And in other hospitals in the tri-state area where they didn't typically have every room as a private room, they've tried. So I know that's where some of the patients are. There are certainly a few that we specifically know stayed home too long and they were frightened to go into a center, and they probably had worse outcomes or more difficult courses because they waited. So we know that happened. But the short answer to your question is volumes in the major programs, at least for leukemia, are down. MD Anderson, wherever you call, because the patients that are typically referred into the major centers were not being referred in. They're being taken care of wherever they are.
Yeah, I'm encouraged, though, that you suggested you had patients with myeloid malignancies that were COVID positive and that they did okay.
I got to tell you, I do not, everybody is saying that, nobody understands the virus. An AML patient, a relapsed AML patient, living at home with two family members sick with COVID, not asymptomatic, sick with it, she's fine. Post-transplant patient, fine. Two people living together, one with a post-transplant patient, another with a myeloproliferative disease. They happen to be a wonderful married couple, and they both had it like nothing happening. Friend of mine who's a physician, they go out to dinner, she and her husband. They help a lady in a restaurant who has fainted and Several days later, they're both sick. He has an easy course of a few days. She's sick for 3 weeks. It's all over the board, whether it's us, whether it's healthcare workers, whether it's patients, but it is not true. So we're hearing reports now from AACR, for example, that, things are bad for patients with hematologic malignancies. I don't know how to answer that yet because I'm not confident enough that my N here answers that question. I can say anecdotally, it is not the case that if you have a hematological malignancy that you are definitely going to have a rough course with this virus, because I have plenty of examples that that is not the case. Broadly, statistically, what the numbers look like, certainly AACR has published some data. And the problem is that lumping together hematological malignancies also is a very risky business, because lymphoma, myeloma, transplant, AML, these are not the same. The patients are on very different medications. And I think that we're going to need to use things like REDCaps and the ASH database and other more central locations to pool data so that we don't have to lump hematologic malignancies together. They are not the same, and I think we should understand each to be a disease individually. We're only going to be able to do that by having the worldwide experience pooled.
Yeah, no, I think that's great.
I think
John?
there's a confounding issue with all this, and Gail referenced the data from China that was presented at AACR suggesting that cancer patients with COVID have a significantly worse outcome. On the flip side, our patients are getting excellent medical care. They have doctors that they see. They're not hesitant to call us up. They are getting seen regularly. They're paying very close attention to this, probably much closer attention to this than what other patients perhaps are able to do or are doing because they're working and doing other things. Our patients are attuned to infection risk. So I think one factor, and I would echo what Gail said, I mean, we have had patients with COVID, and I certainly don't want to say that hematologic malignancy patients with COVID do better, but I think they may in part also be benefiting from the scenarios where they're getting good care. Obviously, everyone's not getting good care, and there are underserved populations with hematologic malignancies that no doubt are doing poorly, like there are underserved populations without heme malignancies in COVID that are having less favorable outcomes. But I think one of the sidetracks, at least of patients that are in a position that they're getting ongoing care, is that they are probably being monitored more, and in some cases more attentive to what could be going on, rather than continuing to work, stay home, think, well, I'm young, I'm not that short of breath, even though I have all of this, and then winding up in a very difficult spot. So it may be a confounding factor there to some degree.
I'd like to add one thing, which I think is just for us in the New York area has been sort of super interesting. So we have not been ever a masked society, right? I've had the opportunity, I've traveled to Korea, I've traveled to Japan. I was often the only person without a mask. And this has nothing to do with COVID. This is way before that. New York has never been like that. And New York in March wasn't like that. So what's interesting, and what I think everybody would love to know the answer to is, and I think we were almost disdainful of it, right? Putting a cloth thing in front of your face, give me a break. How biologically, how can that protect you from anything? The virus is so small. What is a piece of cloth over your face going to do? However, I would make 2 points related to what John and I were just tossing back and forth. The first thing is, I can't prove any of this, but many of the patients with hematological malignancies, especially transplant patients, these are patients who are often masked and gloved and thinking that way to begin with. We didn't have masks, but they had masks, okay? A lot of these patients were used to it, that for flu season in general, or for the winter season in general, if they're riding on a bus or taking Access-a-Ride or riding on the subway in New York. So I wonder whether actually this cannot be studied, but there were many, many masked patients long before it was fashionable to wear one. Also, I live on the Upper East Side of Manhattan, close to where I work. And I can tell you, walking back and forth every single day to work, it's been an incredible transformation. I mean, we were at 0% masks, and then we were at 10, and then we were at 20. And yes, that is quote unquote mandatory, but telling New Yorkers mandatory things doesn't usually work. I can tell you that on my way to work today, there were maybe 3 people in the many that I passed, and traffic on the streets has increased. It no longer feels like a bad movie ghost town here. The stores are largely closed, but there's much more both foot traffic and car traffic, and everybody has their face covered. In fact, with varying levels of coverage. Some people are really glasses and hat and the whole thing. So I think a huge question is going to be, what is the relevance of masks for patients, for doctors, for everybody else? Not talking about going in to see a COVID patient, obviously for that full PPE will always be required. But given the prevalence, given the fact that when you walk in to see someone in clinic, you don't know what you're going to get. How do we reopen? Are we reopening in a full PPE kind of way? Did these masks help our patients up until now and we need to listen to this? This is something that I feel is going to be really critical to sort out over the next few weeks, because people don't have a lot of patience. They get bored. They're getting bored with the whole thing. They want life back, masks on, forget it, move on. Maybe that's the only important thing that we're actually doing, just throwing it out there.
Yeah, no, Carlos, I think I'll give you a chance to respond. And I will tell you, I'm skeptical that masks really do anything. But from what I've seen in terms of data, it reduces your risk by 10%, which is something. That's not nothing, but it's something. But Carlos, tell me what you think.
Well, I think, first of all, we have to say that masks, it's a little bit like talking about cars, right? There are all sorts of types of masks. They're all the way from an N95 mask, which we know what it works for, to a cloth mask. And I think when we talk about masks, I always ask somebody, what mask do you want to are you talking about? Because if you're talking about an N95, as Gail knows, it's uncomfortable to wear, especially to wear all day. It will leave scars in your face, and the seal is tight, but it's the most protective mask for anything coming from the outside to the inside. On the other hand, a surgical mask is a mask that it's more comfortable to wear, and it works in the opposite direction, right? It works preventing things that are in my mouth to getting to other people. And then a cloth mask does a little bit what the surgical mask does, but to a lesser extent. I think the benefit of masking everybody in public is not to protect me, but to protect others. In other words, it's talking about that asymptomatic transmitter, right? Is the fact that if I'm infected today, so again, I think exactly like the surgeon. A surgeon puts a mask, or you put a mask for a procedure because you don't want what you have in your mouth to go into the patient as you're doing the procedure. Well, you put a mask to go out to the street because if you happen to be infected, you don't want, and you are asymptomatic or pre-symptomatic, you don't want to transmit to others. So it's preventing you from giving somebody else as opposed to you catching something. So while I agree with Gail that our patients with hematologic malignancies have worn masks for a long time, when I think about when I round in the hematologic malignancy floors at Emory, as a provider, we've always put masks, but we've put masks to prevent us from taking something into the patient's room. So I do think that there's a benefit from masking, and as you say, it reduces the transmission, the overall risk of acquisition for about 10 to 15%. So I think there's some benefit in masking, and I think as we open and as we go forward, I think masking will become, we're going to be more like Korea or Japan or China, in which masking is going to become more common, at least for some time. I do think that the other benefit is in hand washing. And I think, I'm hoping that our rates of C. diff and rates of MDR organisms in hospitals will start coming down as a side benefit of all the hand washing we're all going to be doing because of COVID. And that will be great, right? It took Semmelweis, since then we've shown hand washing works, but we can't just get people in healthcare to do 100% compliant with hand washing. And maybe as a result of this, we will have 100% compliance with hand washing, but we'll also be more attentive of hygiene in work and in other places. I mean, I think about my computer keyboard, I think about the coffee pot, I think about elevators. And then the other thing is, I think we're going to be more attentive of very large events. And I'm not sure, for example, church events and other events where massive transmission can occur, what kinds of things we're going to tell our patients, when somebody with even though I don't see a higher risk in people with hematologic malignancies, with somebody who is receiving chemotherapy or recovering says, when in the fall, let's say, Lincoln Center reopens and somebody says, can I go to the opera and can I go to a concert? What are we going to tell them? You can't go, or you can go, but you have to wear a mask. I think we're going to how a lot of our patients ask questions about those kinds of things. And I think masking is going to be one of the things we do.
That's really where I was going with the masking issue, is that it's, again, I don't think people fully understand that they are protecting others rather than themselves mostly, but never mind, a little if they think they're protecting themselves, that's still, I think, probably one of the only things realistically that we can do and still open up. I mean, if you think about the story in New York, right? What are we supposed to do? How do you open up a medical center and you can't use the elevator? You have to use the elevator. These patients are ill. They can't climb up the stairs. And anyway, if there are 4,000 people in the staircase, that doesn't help either. So if you think about it, pan immunity vaccine for everybody, we don't have that yet, right? We can't wait for that to open up. And yet, what is opening up gradually? I keep hearing gradually. There is no gradually. Yeah, there is no gradually. You're either getting on the subway or you're not. And when you're on the subway, currently, we have a very vast homeless population actually on the subway. This has been a huge problem in New York, but there are patients who need to get on the subway. And it has to be very concrete. Well, we're going to gradually, you're either on the subway car or you're not. And if you're on it, are we telling you to wear a mask or not? And these are things that have been very flip-floppy over the last month, going from it doesn't matter, you don't need to do it, well, maybe you do it, well, it's optional to do it, now you got to do it. So it's very confusing for the public, it's very confusing for patients, but realistically, for right now, if you got to move and get around and do your thing, intuitively, it's probably the only thing that we can actually do is cover up. And if you ask me whether I think it's reasonable to wear a fluid shield to the grocery store, yeah, I do, because things are very, very packed here. And the probability of the person standing next to you sneezing is a lot higher than you think. And somebody sneezing into your face might actually be enough to catch this disease. So what are you going to do? Not everybody is going to have a hazmat suit. Not everybody is going to have a welder mask on, but I got to tell you, I walked by 4 people on my own streets of New York this morning with full-on gas masks. So people are getting creative in what they think they need to do to protect themselves.
Yeah, I can't wait till the time where we have to have the prior auth discussion over a box of masks for our patients. That'll be
or for as Gail says, for the big respirator mask, right?
Right.
Well, I got to tell you, I'm reasonably sure. I'm reasonably sure I'm going to die of bleach poisoning. I was laughing about the whole scandal with taking the bleach. So we're supposed to, after being in a COVID room, use some, for sure, carcinogen to wipe down the thing that we had before we take the other thing off, etc. And I had the experience yesterday. I've gotten very good at the PPE. I did it exactly as I was supposed to. I did the wiping down of the outer welder shield that I was wearing. And there was a mask under that. I took that off. I swapped that out. That goes over an N95. This is following the process that is in our hospital. And I have to tell you, I had to rip the welder mask off because my eyes were burning. And still, this is now the next day, I am tasting bleach. So first of all, that probably indicates that the N95 was somewhat permeable, but I am actually worried that some of these things that we are doing to protect ourselves, well, if it kills COVID, great, then I killed all the COVID, but I am eating bleach a day after doing this wipe down. So the docs have to be careful too. We have to understand better, what do we really need to be doing here to protect ourselves and the patients?
Yeah, thanks. That's I look forward to that flavor, the bleach flavor. All right, John, let's switch a little bit. And
you said you were not going to get political.
No, I'm not going there. So John, let's talk a little bit about management of lymphoma patients from a month ago versus now, and where you hope to be in a month from now. So were there things that you didn't do a month ago that you're ready to do now? And if the answer to that is no, then what are you going to need to see to be able to do those things, I guess?
Yeah, it's a good question. I think that one of the interesting aspects is patients and patients' willingness to to do things as well. And so, anytime you have to talk to a patient about coming in versus not, getting blood work or not, getting scans or not, that, we used to talk about chemotherapy or other drugs, risk benefits, and now a lot of the risk benefit discussion is, about how much monitoring to do and how to do that. Clearly, telemedicine is here to stay as far as I'm concerned. And there are certainly scenarios, not having labs, not having a physical exam, but I think everyone's practice should be changed so that a substantial fraction of the patients you see will be telemedicine, and that's going to happen, I think, for good. Now, whether it's 10% or 30% or 40% kind of depends on the scenario, but no doubt that's going to be there. As far as kind of taking care of specific patients, I think we have a number of different sets of lymphoma scenarios. One is someone who's newly diagnosed with large cell lymphoma, with Hodgkin lymphoma, who's got a curable disease that might be able to wait a week or 2 or 3, but is not going to be able to wait a month or 2 or 3, or we're not going to feel good about that. I think all along we've been treating those patients. And so I have patients that have started R-CHOP or ABVD or other approaches, and we just march right through it. A second scenario is the other end of the spectrum, the patient with a relapsed aggressive lymphoma who needs, a transplant, needs second-line intensive chemotherapy, needs CAR T cells. And that's kind of the same scenario because that person is not going to be sitting around. It's like the equivalent of the leukemic patient who's got blasting off disease. That person's not going to be better in a month or be able to sit around for a month. And those people we've gone ahead with. The main area where there's wiggle room is the follow-up patients on surveillance or on monitoring or on watch and wait. Patients who have a little bit of adenopathy, I would ideally be examining them. I'd ideally have labs. Maybe the nodes are a little bigger or still there by the patient's report. And those are people that we're largely just monitoring by a telemedicine visit and saying, how are you feeling? Are you doing okay? If so, we kick the can down the road a little bit. And then the other group of patients, I think, has an analogy to that, but different, and those are maintenance patients that are on maintenance for rituximab or obinutuzumab for follicular lymphoma, for mantle cell lymphoma being the most common scenarios of those. And those are people where we've largely taken a pause in their treatment and said it's not a big deal to miss, one maintenance therapy, and we'll reassess it in a couple months. And then the last group is the clinical trials group, which maybe we'll come back to later, because I think that's a whole nother kettle of fish, and anybody in oncology has some patients that are thinking about that. But I would say the buckets are really that kind of intermediate gray area. The vast majority of other people, we're doing what we have to do. But the follow-up ones are the challenging ones because you're kind of, well, do you feel any new lymph nodes? Okay, I don't see any through the TV. Okay, I guess, we can kick the can down the road a little bit.
So let me ask you a couple of quick specific ones. In mantle cell, relapsed or refractory mantle cell, did you do a lot of switching towards BTK inhibitors? Did you stop BTK inhibitors? Did any of that play in a month ago?
I would say no. I would say that I have not changed from one treatment to another based on COVID risk. I've had people ask me about that, but my general approach has been not to rock the boat. Maybe pause something, but not change from one treatment to another.
Okay, and just in terms of BTK inhibitors in general, and we'll get to this when I mention a little bit about myeloma. There's a lot of Twitter chat about, do you continue Len? Do you stop Len? Where do you guys fall in terms of BTK inhibitors? And they can make things worse. They might make things better. We just keep them as they are.
Yeah, there was, as you know, there was a very brief report in Blood about ibrutinib and Waldenstrom's macroglobulinemia. I think it's very hard to interpret, but at least a suggestion, and I think that's a generous way to put it, that might have improved outcome for a patient or two with COVID. I think that there are clinical trials of acalabrutinib going on specifically in COVID. And I think, the pathway and the role of B cell activity, as well as other kinases off target, are of great interest. I would say that I have not changed anybody who's on a BTK inhibitor, meaning I've not said in a CLL patient who's doing great, let's take a pause. I've just left them alone. I at this point wouldn't have a problem starting one if someone needed it, and I thought that was the best treatment.
Okay, all right. So Gail, let's talk a little bit again about sort of myeloid malignancies. And I know before the mantra has been, there's nothing elective about myeloid malignancies, so we're going to do everything we're going to do. But there must have been some things that you made some changes in terms of your practice a month ago that you're now ready to reopen up to the way you normally do things.
Yeah, I have a lot of calls about sort of what am I doing in the COVID era, and I'm not exactly sure. So you cure the curable patients, right? I'm with John on that 100%. And we have had patients come in with 90,000 white count with new AML. The practice changing thing has been, yes, we are checking them for COVID, and we are checking on our inpatients actually routinely. And for some of the inductions, and we've gone ahead and done the inductions the way that we would normally do them, but if they have a neutropenic fever, we're doing another COVID test because, first of all, there could be potential for nosocomial spread, although we're being very careful. Secondly, it might have been that something was a false negative. So I would say from a practice changing point of view, COVID is now on the list of things that we keep looking for. With respect to treatment, I have tweaked. So there were some older patients on venetoclax and on HMA-based regimens where I might have been on track to give a post-remission cycle. I've delayed. I've dose modified for a few patients based on no data. This is based on me trying to be a good doctor and saying, well, last time you dropped your counts when I gave you 5 days and 10 days, so now I'm going to lower it a little bit. I've done that, and of course it's too early to see what the effects of that are, but I have kept my post-remission patients out of the hospital and not having had them admitted with neutropenic fever during the last month. I do think it was the right thing to do to kick the can for, as John said, 3-4 weeks so that everybody would get their gear together, would figure out what are the things that we can do to be somewhat protective. I think that was a good thing. But I have not grossly changed my practice. One thing has changed, though, and is here to stay and is a difficult topic of conversation, which is the visitor situation. Mm-hmm. Because for many of the things that we're talking about, whether it's AML induction or whether it's transplant, whether it's CAR T cells, these are things where patients are isolated in the hospital for 3, 4, 5 weeks at a time. And that's hard. It's hard on patients. We are trying very hard to be super supportive. We are trying very hard to get up and running again for CAR T, for transplant. We thought there was going to be a problem with ICU backup and ventilator backup for these patients in case they got sick. There isn't. We're ready to go. But the problem is, I don't even know when we could possibly let visitors into the hospital. So it is the case that the conversations with some of the relapse refractory patients, with some of the much older and frail patients who we think really may not have a good chance of going into remission, I think our usual aggressiveness and gung-ho might be tempered a bit. And I'm actually spending a lot of time on conversations about what that's going to be like to not be in the hospital. And I will tell you that of the conversations that I had, and they were so hard to have with patients, encouraging them with, again, these are relapse refractory patients where you're not going to be curing them. I've had patients where I had them leave the hospital where I otherwise wouldn't have, or not admitted them when I would have. And I have to tell you, I have a collection of emails already, which I'm treasuring. They're helping me get through this, thanking me so much for doing that, because patients and families were reading the stories about the news, about being separated from loved ones, about saying goodbye via iPad. And in a few scenarios where we've been able to have that not be the case, I felt like we did the right thing. And I do think that going forward, I don't know when visitor policies are going to open up around here. Certainly in other parts of the country, they are already easing visitor policies in hospitals. But I think that has to be a really careful part of the conversation, especially with patients who do not, unfortunately, have cure on the table.
Yeah, no, I think the visitor policy is a hot topic here as well. And I think what we've managed to at least do for the long-term players, meaning people that are having a transplant, leukemic induction, where they're going to be in for at least 2 weeks, probably more. We've right now are pushing for a single caregiver that stays in the room, that doesn't leave, that's been quarantined for 2 weeks before they come in the hospital. But I think your point raises another important question, which is, as we go forward with starting to treat more people, whether in or out of the hospital, routine testing for COVID-19 pre-initiation of therapy is likely something that's also going to be done more. And are you, both of you guys, going to be thinking about doing that for everybody getting treatment that could make them neutropenic potentially?
Yes.
Yes, and we have every day somewhere between 100 and 1 million hours of discussion about this, because the question is, in clinic areas, right?
Yeah.
So you're tested on Monday. All right, well, then you go shopping and you go out, or you, whatever, your kid comes home. So what is the correct frequency of retesting? What is the correct PPE for seeing patients in the outpatient department? What is a reasonable structure in an infusion center, where for things like photophoresis or other procedures that might have you in close communication with a provider? You know, so I think that these discussions are very, very much happening, both for patient testing and retesting and for provider testing and retesting. And I think it's worth bringing up that that false negative rate of 30% is brutal. That is painful to all of us, A. B, we all have seen examples that if that swab isn't a brain biopsy, it's not a real swab. And it's not that easy sometimes to get the swab up to the patient's eyeball without something happening. It's a hard test to do. We would love something easier. And then the icing on the cake is that we are seeing, both in patients and increasingly actually in non-patients, that the test is positive for a long time afterwards. We've all had these scenarios where we laugh that we won't swab ourselves for a regular respiratory viral panel, because if we have rhinovirus, we'll never be able to go back to work for a year. So here too, there are patients and there are healthcare workers who are being consistently positive 30 days out, even though they are totally asymptomatic. So what is that? Is that viral shedding? Is that relevant? Is that important? Are you going to deny them going in for their chemotherapy? These conversations are really hard, and I would say it's a work in progress.
Yeah, so I'm going to ask Carlos to weigh in on the visitor, on the swabbing thing, because I think there are some new ways to swab that are not quite brain biopsies, is what I've heard. But John and Gail, so you're going to test people before each cycle of therapy. Is that the plan?
I would say it depends.
That's what we're moving. That's what we're moving toward. And I think, you know, at the end of the day, as Gail said, I mean, A, would you delay therapy on a patient? You might in many cases. And B, you know, where are you going to put that patient when they're getting infused? And you know, we have had a separate area for known COVID positive patients. Right. Yeah. And have directed patients, particularly Gail's patient, leukemia patients who need that and can't be deferred. So, you know, I think it's, and as more and more testing capacity has come up, it seems to be a very appropriate thing to do. And we're also, you know, working on plans to test staff as well, so that, you know, we can all feel good that the environment that we're in, and patients can feel good that, you know, all of the measures we can take are minimizing risk.
Yeah, yeah, no, I think that's, so we're proposing anybody that needs growth factor support for a regimen is somebody that we're going to test once per cycle, recognizing that they could be negative today and positive a week from now, and you're already committed, but there's really nothing you can do about that.
Sure.
So Carlos, can you talk to us a little bit about the false negative issues that Gail was raising earlier? I know in our ER, we're doing that rapid point of care testing that actually is much more sensitive than we thought. And I'm curious where you think we're headed with testing efficacy.
So a couple of things. There are a lot of testing, and you know, the original traditional testing is obviously getting a nasopharyngeal swab, and a lot of the false negatives are from two reasons. Number one, because it wasn't done appropriately, because as you know, having been swabbed myself, I said, when they said your test is negative, I said, yeah, but did you see the brain biopsy you took? And you know, it's a pituitary biopsy that you did in the meantime. It's clearly not a simple procedure, right? But if it's not done appropriately, you can have false negatives as a result of that. You also have false negatives because or later on when you get more disease in the lungs, you may not have as much recovery up in the and we've seen patients that are negative in the nasopharyngeal swab, but then they get intubated and they're in the BAL, they're positive. So the sampling is one issue. The two rapid tests out there, at least, one is the Abbott test that actually has a limit of detection of about 100,000 copies. And the other one is the Gene Expert that has a limit of detection of 250 copies, which is very similar. So the Gene Expert is a good one. That's the rapid test we're using in the ER that you're talking about. The main problem we're having with the Gene Expert is that there's simply not enough cartilage out there. So the cartilage that you need for doing the testing are not being produced by Ceph yet fast enough. So once we have that more of those available, I think those rapid tests are going to be good. You do have an issue with throughput. You can only do one at a time. So I was talking, for example, Midtown Hospital, the lab can run 80 of those a day. They can run more just because they don't have the equipment nor the technicians to do more. They would need more equipment and more technicians to do more rapid tests. The high throughput machines like the Abbott machine or the Roche machine, those can run many more tests, but then you have a lag time of several hours. So you're talking about getting the test in today and maybe getting the result this evening or maybe 24 hours later. Then you have the sampling, right? We are doing several studies testing oral swabs and even oral washings or saliva. I think in the future, some of those are going to be useful. I still think better testing is required. Also, the White House is working with laboratories, with lab developers to move on in developing antigen-based tests, not PCR testing, antigen-based tests, very similar to what we do for the flu. And I think by the fall or later in the year, we will have antigen-based testing. And that, I think, is going to be really a very different, a game changer, really, as opposed to PCR testing. And then finally, we have the antibody testing that at this point in time is really the wild, wild west. There's all sorts of tests out there. There's all sorts of specificity and sensitivity. And we're not at a point that we can say, do an antibody test, but I think we will be in the future very soon. For example, I've been looking at some of the data of some of the tests that have been developed. You can get a very good test an antibody test that may become positive as soon as 5 days after infection. And if that's the case, it may be a useful test not only for screening, but quite frankly, for doing the kind of testing that you're talking about, right? Of following somebody, and maybe your hematologic malignancy patients get an antibody test. If they're positive, you don't worry about it. If they're negative, you do testing every time you induce them. So I think the way we incorporate testing into our practice is also going to be different. And I think will change as different testing becomes available. But I think it's going to become really part of what we do, this testing issue. I did want to comment on the visitor issue because I do think that while I see where those policies are coming from, I really worry about patients that have a really tough time in the hospital, hematologic malignancies, bone marrow transplants, and that have nobody to be with. And I do think that looking at innovative approaches of figuring out how we can have people, I don't want to have a crowd there, but at least have some ability for people to come and visit and spend time with their family members is critically important. And I think that also some of those, we're going to get creative and figure out ways to maybe have certain areas of the hospital dedicated to COVID or other things that will allow us to continue managing patients in a more humane way, because I do worry about this whole idea of, people dying alone is not what we should be.
Yeah, thanks, Carlos. I just taped that conversation because right after we get done with this, I have a phone call with the higher ups to discuss that very issue. So now I've got an expert on my side, so that helps.
Well, I defend you because again, I want to be. We need to balance, safety with common sense and humanity, right? And that's a very difficult challenge for many people to see. But we have to see if they were telling me today, hey, your spouse is dying and you cannot see your spouse because of COVID, I would say, I don't care, I'll take the risk, right? That's fine with me, and give me the PPE, and I take the risk happily. And if you have me sign a document, I'll sign it. But I just don't see why I should be prevented from doing what I think is the right thing.
And some of it probably depends on the situation. In New York, you guys really had no choice. It was so endemic that I think any kind of risk that you brought into the hospital was protecting the sanctuary, if you will. I get that, but I think as we're starting to grow up and ramp up, we need to think about, as Carlos said, ways that we can allow patients to have, especially, I mean, there's nothing easy about a transplant. And going through that by yourself is I think it's pretty tough. So.
I mean, look, when we talked last time, right? Okay, we had tents popping up in Central Park. We had
Right.
boats driving in. There were vents everywhere. We were talking about thousands and that. We didn't know. And I don't play that. I don't Monday morning quarterback. I don't like that. There's no, we didn't know. It felt scary. There are crazy things happening with patients. They're having weird clotting problems and neurological problems, and people are getting sick, and the numbers are horrifying. And they're, like I said, tents popping up in Central Park. I understand the, oh my God, shut down, shut the door, give us a minute to figure this out. So again, understandable. Having lived it, it's very confusing, very difficult. However, if there are things that are shifting, well, then we shift along with them. And the truth of the matter is that if a patient is going to be in the hospital for 2.5 weeks for treatment of a hematological malignancy and then go home and then go to clinic, it is absolutely illogical to prevent visitors, because by definition, if you're opening the doors and if visitors are coming in and you're going to clinic and you're going out and you're taking the subway home, what is the point then of having been in the hospital for 2 weeks without a visitor? And furthermore, the doctor is going in, the nurse is going in, the environmental services person is going in. Fundamentally, there are a lot of people going in and out. So nobody did anything to be inhumane. Everybody was frightened and trying to protect. And that's certainly how it's appreciated, I think, by the patients.
Absolutely.
But the question now is, how do we turn things more logically based on the fact that if you are going to be home and interacting with people and taking public transportation, then bringing you into the hospital and having no visitors makes no sense.
Well, coming back to testing, I mean, that's basically it. In the scenario you describe of the family member of the person getting a transplant, if they're going to stay for a week, you test them before they come in, and once you're reasonably certain that that test is a true negative, then, whether it's 1 time or 2 time or whatever, I think that it's a pretty good screening test to resolve most of your problems.
Yep.
Yeah.
Agree.
Yeah, I agree. So I'll, as I know that the hour is starting to get towards the end here, I can tell you certainly in the myeloma era, we talked before about trying to minimize visits to clinic, switching to once-a-week regimens where we're able to. Again, a lot of these are dependent on how sick the patient is and whether you need to get that twice-a-week dosing or once-a-week dosing is okay. I think the good news, at least on our side right now, is that we are starting to really begin to plan some of those auto transplants that we put off for March and for April. We're starting to get them on the books in May. And I think the question that I think is really important from the perspective of that John raised earlier is the clinical trial question. So I think when we spoke last time, you guys had shut all of them down, if I remember correctly. We didn't shut them all down. We've actually continued enrolling probably at about 40 to 50% of where we were before. But now I think all of us recognize that trials have gotten us where we are today. We got to figure a way to turn them back on. How are you all prioritizing those kinds of issues now?
So we never completely shut things down. We kept people on protocols that were already on. And we had some liberalization, as I think everyone is, as to the realities of the situation. And for clearly life-threatening issues, we've been allowed to enroll people. But there's some discussion, and I would say that your 40 to 50% is probably about right in the relative proportions, and you can make stronger or weaker arguments one way or another. And I think, right now we're in the same scenario, getting ready to gear back up, thinking about how to do that safely. Also, we've been, some of our clinical trial staff has been working on COVID trials. And so, we're kind of bringing people back home to the extent that we can to do those things. So I think we're working through all of that, and, it'll continue to be a work in progress.
Absolutely.
Gail, did you want to add anything or?
Look, I treat acute leukemia. Clinical trials is it's absolutely critical for us. I think that we've done our best to keep people on trials. As John said, modifications and things that weren't previously allowed are now allowed. So maybe that is going to be a silver lining. Hopefully, I'm always looking for silver linings. So maybe some of the inflexible things are now a little bit more flexible. Maybe that'll be a good thing. Maybe we can mail a PO drug to a patient more easily than having to sign 40,000 documents to do it. But we want to open up. We want to open up. We want that for our patients, and we are hoping any minute now to be back up and running. It does go to show you, though, you need a lot of people on hand to run a clinical trial. It's a lot of manpower and woman power, and in order to do that, that means a lot more foot traffic, both in clinic and upstairs. So it has to be managed.
Yeah, I agree. So I think we're getting to a point where we can begin to wrap up a little bit. So I want to give you each your last moment for the audience to start off with. So John, what advice or recommendations do you have for folks and your parting words? And let me add one more thing that you can answer. PET scans are tough to get right now. They have been tough to get, right? How have you been assessing responses during this period of time, or you're just calling it good by your magic through the TV?
Yeah, I mean, you could argue it that very few people have ever died because they didn't get a PET scan. But that being said, I mean, if it's going to change what you do a PET scan. You know, there's a lot of wiggle room as to the time frame of when you do it after treatment. You can wait a little while. And in the middle of treatment, you usually know pretty much what's happening with the patient without a PET scan. So we've been kind of pretty relaxed about this, but I think that takes home my final comment, which would be that this is, like everything in medicine, a very individualized decision, and you have to really deal with the patient's specific situation. The external forces are what they are, and you do your best to do what's right for the individual sitting in front of you.
All right, thanks, John. Gail, parting words.
Cure the curable. So this is oncology, and when we have curable patients in front of us, we just have to, do it as safely as possible. And I would say my parting words are: we want the optimism. The curves are going in the right direction, but we can't let our guard down yet for either ourselves or for our patients. So I think that the positive news should not be interpreted as "don't worry about this virus." It's still a scary one, and we should do things that make sense and that are reasonable to be protective while still giving the care to our patients that they need.
Yeah, that's great. Thank you. And Carlos, and if you could focus a little bit on potential future treatments as well. I know in the oncology world, our drugs are being hijacked to help treat COVID. I know that selinexor has got a trial that's going on. Plitidepsin has got a trial actually at Emory that's going on. And I hear our radiation oncologists are using radiation in some situations as well. So give us some hopeful views on the future of treatment.
Well, again, what Gail said, we advance science and we advance cure for our patients through clinical research and clinical trials. And we need to, all of us need to be supportive of clinical research and clinical trials. This is how we find answers. This is how we find, I was talking to a reporter today and I was saying, it's not, people are wanting a home run, they want something and they want a home run. And this, playing this game is a series of solid hits. And that's how you win the game, by having very well done clinical trials. And I think the clinical trial infrastructure we have developed around oncology, around HIV, around the different networks that have been supported by the NIH, now we're all helping to do the COVID clinical trials. But that infrastructure that has existed in clinical trials of people capable of doing very well done clinical trials is actually what's being used to do the COVID. They didn't have to develop a COVID clinical trials network. They just jumped on the HIV and the cancer and other clinical trial networks that were well-oiled machines that work well and that knew how to conduct clinical research. So clinical research is so critically important and something that we are learning from each other and that we are collaborating with each other in ways that I think there's a couple of things that are very good about this pandemic. Is number one, we're developing new relationships, new colleagues, new opportunities, not only locally but globally. And number two, I think we're seeing a tremendous response from the community as far as supporting and the support for healthcare workers everywhere. And I think we need to be thankful for that, but we also need to capitalize on that. I mean, a lot of times people said, I don't want to go into medicine because I may get sued. I want people to say, I want to go into medicine because this is where the heroes do. That's where, that's the place where you actually get to make a difference, which I think we're making a difference on it every day. And I think the third lesson is that this is a scary virus, as Gail said. This is not over, and when this is over, there will be other pandemics and there'll be other epidemics. And I think we just need to think about what sort of the autopsy, the postmortem is going to have to be done about what we could do better next time to prevent something like this from happening again. And there are many things that could be done globally, but there's many things that we could do locally. And I'll just put one example. As many pandemic influenza plans as the government had developed, I don't know if you're aware of, but none of those plans included N95 masks as something that was necessary. And therefore, the national stockpile did not have N95 masks available because nobody thought that they were needed. So obviously, a lot of holes occur and a lot of problems that hopefully next time won't happen. So there's a lot of lessons to be learned as we get out of this. And it's not just saying, oh, we're done, let's move on. But really, what are the lessons learned that we can make our health system better? As John said, more telemedicine, more other things, our research better. You know, I'm loving the idea of people are talking about, you know, touchless research or less touch intensive research trials. That's really different, but we're doing those and they're coming along well. And then, you know, what can we do as a society to prevent this from happening again? Because I sure don't want to go through this one again, at least not in my lifetime.
Yeah, no, I think that's really helpful, and I appreciate the look going forward. You know, I think about that line that I'm sure all of us have read from The Plague about what is a doctor's job to do during this kind of a situation, and the answer is we're supposed to do our job. That's our job. We just do what we were trained to do. And I think all of you and all of our colleagues have really done that. So again, thank you to all of us, to all of you all for joining us today, and to my colleagues for participating. We hope that you've come away from this discussion with practical knowledge that you can apply to your practice. The next COVID-19 webinar is confirmed for Wednesday, May 6th from 12 noon to 1, featuring Dr. Neil Shore, Dr. Petros Grivas, Dr. Ben Gartrell, and Dr. Daniel Petrolak, and will focus on the impact of caring for patients with GU malignancies. Additional COVID-19 webinars are also planned for May 14th, focusing on GYN malignancies, and May 15th with a focus on lung cancer. We encourage you to register for each of these activities as registration details are made available. Thank you again for your attention. Thank you so much for the great discussion by my colleagues. I can't believe an hour just flew by, and have a great day and be safe.